Today, let's talk about V-Tach versus SVT, and more appropriately, aberrant SVT. So, in each case, we have this wide complex tachycardia. And is it V-Tach or is it SVT? Because our treatment's going to differ a little bit. Our approach to this patient is going to differ. Um, Sometimes pretty drastically between V-Tach and SVT. So let's talk about our wide complex tachycardias and how to distinguish V-Tach versus an aberrant SVT. May sound just silly at first, but sometimes we get a patient with a tachycardia and it's a wide complex tachycardia, and it's, is it V-Tach? Is it actually V-Tach? Right? Maybe we have a perfectly stable patient. Is it V-Tach, or maybe is it SVT with some sort of aberrant conduction? Maybe it's an SVT with a bundle branch block. Maybe it's a WPW. Maybe it's some sort of pre-excitation syndrome with a tachycardia. So we have a wide complex QRS. It's tachycardic. That doesn't automatically mean that it's V-Tach. It doesn't automatically mean that it's SVT with aberrancy. So which one is it? Should we go down the V-Tach route? Should we go down the SVT route? Before we even get into the 12 lead, the EKG itself, we have a wide complex tachycardia. Well, a good patient history is going to tell you like 90% of what you need to know. So in our older patients, if you've got, an 83-year-old patient, it's probably V-Tach. They have a cardiac history, past MI, CHF, cardiomyopathy, heart disease. It's probably V-Tach. So pay attention to your patient history. Don't forego that patient history, because that's going to tell you most of what you need to know, even though it looks weird on the 12 lead, weird on your EKG. Your patient history is going to be paramount. Um, if you're in doubt at any time, we're going to go through some criteria, through some steps. If you're in doubt, we're always going to treat as V-Tach, because V-Tach is the more deadly of the two. So we're going to treat it as V-Tach, and if our treatment doesn't work, it's probably the other one. It's probably SVT. But we're going to err on the side of caution in this case. So if we're doubtful, we go through all of our criteria. We're like, I still don't really know. We're going to treat it as V-Tach and kind of take it from there. Right, so we're going to talk about a number of criteria. One of these criteria is Brugada's sign. So we're going to measure from the start of the QRS complex. Again, you're taking out those calipers that you ordered like weeks ago, and I know you ordered weeks ago because you're awesome like that, right? We all have calipers. So you're going to take out your calipers. We're going to measure from the start of the QRS complex to the lowest point of the S wave. So start of the QRS complex to the lowest point of the S wave. If it is 0.10 seconds or greater, that checks our box for Brugada's sign, and we probably have V-Tach. So this is a positive sign. This is a rule in for V-Tach. If we have Brugada's sign, we probably have V-Tach. Another criterion, this is independent of Brugada's sign. This is Josephson's sign. And if you see, as we go into the S wave, down towards the S wave, on that downward stroke, if we have a little hunk to junk, if we have a little notch, a little quadrunk right there, that is Josephson's sign. And that's another sign, again, independent of Brugada's sign. So I'm guessing, Dr. Brugada and Dr. Josephson, they each needed their own papers to publish, right? So this is Josephson's sign, independent of Brugada's sign, even though we probably have Brugada's sign right here. This is it looks like the same exact complex. We have Brugada's sign here. We have Josephson's sign down here. So we have two indications that this is probably V-Tach. So again, another rule in for V-Tach. So if we're thinking, is this V-Tach? Is this an SVT? If I see Brugada's sign and or I see Josephson's sign, I'm thinking V-Tach. And then let's talk about Brugada criteria. So instead of Brugada's sign, which is just one criterion, one thing, Brugada came up with a set of criteria for differentiating between V-Tach and SVT with aberrancy. And this is what I pull out every single time when I'm thinking like, is this V-Tach? Is this SVT? Right? And I say every single time, like it happens every single day. Like, right? So the handful of times that this has happened to me, pull out Brugada criteria right away. I would say don't commit this completely to memory. Know about it. Know a couple of the big criteria. Don't completely commit everything to memory, because we have field guides. We've got smartphones with Dr. Google on it, and that's what I've done. I've gone to my field guide and pulled up Brugada, but I know that Brugada criteria are there. Right? So Brugada criteria, there are four main points. First one is the absence of an RS complex in all precordial leads. And what's that say? That says concordance in our precordial leads. That says negative concordance in our precordial leads. Pretty easy. There is no RS complex. We just have concordance. Our second criterion is an R to S interval greater than 0.10 seconds and at least one precordial lead. Well, guess what? Well, that's Brugada's sign. Look at that. Imagine that Dr. Brugada put Brugada's sign into his own Brugada criteria. So we covered the first two. First criterion, precordial concordance. Second criterion is Brugada's sign, an overly wide QRS complex and at least one precordial lead. Third criterion is AV dissociation. So usually there are no P waves in V-Tach, or sometimes there are P waves here and there, but they just don't talk to the QRS complexes. They're completely dissociated. We see this also in a third degree AV block. So if there are P waves, they're just not talking to the QRS complexes. PR intervals all over the place. P waves might look different, it might have different morphologies, but we've got AV dissociation. And then the fourth criterion is this morphology criteria, which we'll get into a little bit here in a moment. It gets like real deep down into the weeds. But if we see that first criterion, we can pretty accurately say that's V-Tach. So all these are rule ins. So if we see one, we're like, yeah, that's probably V-Tach. So that first one, concordance, precordial concordance, we're like, yep, that's probably V-Tach. If we don't see that, we can move on to the next one. Do we see Brugada's sign in any one of the precordials? If we do, it's like, yep, that's probably V-Tach, and we can stop. But if we don't, we can move on and say, do we see AV dissociation? If we do, it's like, yeah, that might be V-Tach. We're still going to check for third degree heart block. But it's like, meh, it might be. So as we move down these criteria, we're getting a little bit less and less sensitive, but there's still rule-ins for V-Tach. I want to get deep down into the weeds and get to that fourth criterion, this morphology criteria. What this does is we look at this wide complex tachycardia and say, is it looking more like a left bundle branch block or looking more like a right bundle branch block? We know that it's neither of the two because we've already ruled that out. But does it kind of look right? Does a morphology look like a left bundle branch block? So, in this one, looking like a left bundle branch block is V1 negative. Do we have maybe those upright monomorphic complexes in lead 1 and V6? And then we look at V1 and V6. So we look at, is it kind of looking like a left bundle branch block? So we look at V1 and see, like, what does the R wave look like? What does the S wave look like? Do we have a notched S wave? So now we're looking at that Josephson sign. So have a notched S wave in V1. Then we're looking at a V6, right? And we're looking for Q waves or a QR complex or a QS complex in favor of V-Tach. If we don't have a Q wave, it's probably SVT. Right? So if we have that monomorphic upright complex in V6, it's probably SVT. This is getting real down deep into the weeds once we get to the Brugada's morphology criteria, but it's there for us to kind of poke around and evaluate. On the other side, again, do these complexes kind of look like a left bundle branch block or look like a right bundle branch block? Right, so we're still looking V1, V6. We're looking for R waves, but if they're this RSR prime in V1, if we see RSR prime, that favors SVT. We're not out of the woods yet, but it kind of points us in the direction of SVT. In V6, that R-DAS ratio we're looking at, if it's less than 1, we're thinking V-Tach. If it's greater than 1, if it's more positive than negative, we're thinking SVT. So this is the last criterion in Brugada's criteria. We're kind of getting deep down into it. If we haven't figured out that it's V-Tach or SVT by now, we're really kind of digging and looking at specific waves. So this is when I say don't commit this to memory completely. Just know Brugada's criteria has a few major points, four main points, and we can whip out our field guide and go into, if we need to, go into these morphology criteria and pick apart V1 and V6. Last of all these criteria I want to talk about is this AVR criterion. And I think it's my first stop always, because I think it's the simplest, and it has a really, really high kind of sensitivity specificity. So we look at AVR. So now we're paying attention to AVR. It's been in like an entire semester. We're finally paying attention to AVR. Look at that. So let's look at AVR. I don't know if it's V-Tach. I don't know if it's SVT with like a weird aberrant pattern. I'm looking at AVR. If there is an initial R wave, if my QRS complex starts at baseline and then goes straight up positively into an R wave, that screams V-Tach, because now we have this northwest axis, or we're adding it to this axis, this northwest axis. So AVR is upright, right? So I go into this initial R wave. AVR is upright. Lead 1 should be negative and AVF should be negative. So I should be in this extreme right axis deviation quadrant. And that would make sense in V-Tach, because instead of going up, down, and to the left, right, into the normal quadrant area, I'm starting in the normal quadrant area and going straight backwards into that extreme right axis quadrant area. So lead 1 should be down, AVF should be down. And then I look at AVR, and AVR, I have this initial R wave, and AVR should be positive because that's where my window is. That's the only window that sees a ventricular rhythm as a positive wave. So AVR should be positive. I should have an initial R wave. Now let's look at a few 12 leads. I've got this thing here, and if you have just kind of side note, if you have an unstable patient and they're in a wide complex tachycardia, whether or not it's V-Tach or SVT, our treatment is the same. We're going to cardiovert right away. So if you have a unstable patient, treatment doesn't really change. So this is kind of getting into it where we have a stable patient and not really sure what to do. And I'll give you an example. I was working for a critical care transport agency. We went out to a community hospital where this woman had come in with a tachycardia, and they had been treating her for 8 hours, and she kept going into this wide complex tachycardia. She was in and out of it, came and went, and she stayed stable throughout the tachycardia. Portions of it, her blood pressure dropped a little bit, and she felt like a little funny, a little fluttery in her chest when it happened. But they had been treating her for 8 hours, and nothing was working. So they called us to transport her to the urban hospital, the primary hospital that I worked for. And that's when we pull out all these criteria. This isn't for your unstable patient, because an unstable patient with a tachycardia is wide complex tachycardia treatment's going to be somewhat similar. So just cardiovert them. So this is a stable patient. Just keep that in mind, please. But let's look at this one. Is it V-Tach or is it an SVT with aberrancy? It looks big, it looks wide, it looks nasty, it looks terrible, right? So looking through this Brugada criteria, we do have precordial concordance. They're all going in the same direction. They're all like negatively deflected. Look at that. So that checks that off. So I'm thinking V-Tach. Well, do I have Brugada's sign? Are these complexes, in the precordials, focusing on the precordials, abnormally wide, and yeah, maybe just barely abnormally wide. So we might be just on like the precipice of Brugada's sign. Do we have Josephson's sign? I see Josephson's sign over there. I see it over here and over here and over here. So on the downslope of our S wave, we have a little notch. So I'm thinking V-Tach. Do we have AV dissociation? We sure do. I don't see any P waves at all anywhere. So AV dissociation. If there are no P waves, then we have no A. So we of course have AV dissociation. AVR criterion. If we go from baseline into the QRS complex, do we have an initial R wave? Well, there's my baseline. We have a little bit of a wandering baseline in AVR here, but there's my baseline, and here's the start of my QRS complex. So I have an initial R wave, goes straight up. So I'm thinking V-Tach, and this patient is, in fact, in V-Tach. What about this one? This one still looks like big, wide, nasty, like funky, like, oh my lord. So if I looked at, oh my god, oh my gosh, right, in lead one, if I pulled that up, it might kind of look like V-Tach. If I pull or lead 2 up, it's like that looks funky. I don't really know what that is. So let's take a whole 12 lead. We have a stable patient again. So going through Brugada criteria, do I have precordial concordance? We don't, right? So that's kind of right there. It's kind of negative, a little bit more negative-ish, a little bit more negative-ish. That's positive, positive, positive. That's a little bit more negative-ish. So we don't have concordance. That's fine. We can move on to the next one. Do we have Brugada's sign in the precordial leads? Going in a negative, we don't. We don't have Brugada's sign. We don't have a complex wide enough, a negative complex wide enough. Do we have Josephson's sign, which is separate from Brugada's criteria, but we're still gonna talk about it. So on the negative slopes of our QRS complexes, do we have a little notch? And we don't. Okay, so we're still thinking away from V-Tach. All these are rule ins for V-Tach. They want us to catch V-Tach as early as possible, because that's the bad one. That's the worst one. So I'm being steered away from V-Tach right now. Do I have AV dissociation? Well, nope. If we look in V2, we see P waves. And P waves are just a dead giveaway. So we have P waves, and they are associated one-to-one with each QRS complex. They look fairly, the PR interval looks fairly normal. We're good there. If we go to our AVR criterion, does it go into an initial R wave and go into baseline, even though AVR is mostly upright? Primarily upright, the initial wave is a Q wave right there. So initially it doesn't go positive, initially it goes negative, which is, all put together is telling us that this is an SVT with an aberrant conduction pattern. So we can reach for our adenosine instead of, say, our amiodarone. All right, third and last one for you to take a peek at. Again, we've got a stable patient. We do a 12 lead. If we got this funky wide complex tachycardia, what is it? Is it an SVT with aberrancy? Is it V-Tach? Well, let's go through our Brugada criteria. Going V1 through V6. Do we have concordance? We have negative concordance, right? Looking at a baseline here, looking at baseline here, baseline here, baseline here, baseline here, and baseline up here. All of our complexes are primarily negative. We have negative concordance. Do we have Brugada's sign? These look a little bit too narrow in the precordials to have Brugada's sign, so I would say no. So we can keep moving on. Do we have AV dissociation? Maybe, right? Are those maybe P waves up in there, right? Are they not? I don't know. There's some question, right? So some question. Maybe you see them, maybe you don't. So there's a question in there. Let's move on to our AVR criterion, where we have baseline right here. Is there an initial R wave? And yes, there is. It goes straight up into your QRS. So this is, for the most part, pointing us towards V-Tach. This is when to, listen to the computer and don't listen to the computer. It's just going to tell you a wide QRS complex. It's going to, stay its own legal self and not, be committal there. We're going to call it V-Tach and treat it for V-Tach. So another side note on all of this, you got a wide complex tachycardia. You think it's one, you think it's the other. When in doubt, think V-Tach. But if you're thinking V-Tach, you treat it for V-Tach, you give it amiodarone or lidocaine. Nothing helps, nothing works. Well, it's probably the other one. It's probably SVT. If you think it's SVT and you treat it with adenosine or maybe cardizem and nothing happens, nothing works, it's probably the other one. So, circling back to my patient that I picked up at this community hospital, they've been treating her for 8 hours. They've been treating her with amiodarone. She kept going into these wide complex tachycardias. We said thank you to the physician, got her into our truck, ran a couple 12 leads when she went straight into a tachycardia with us, which was timed perfectly, and ran through all of these criteria and said she is failing most of these criteria. She is maxed out on amiodarone. She's been given lidocaine. It hasn't worked. She doesn't have a cardiac history. She was maybe 40 years old. No cardiac history. Younger woman. It's probably an SVT with some sort of aberrancy. Right? So what did we do? We called it into our cardiologist. Said this is probably not V-Tach. They've tried everything with her, V-Tach wise. She is stable, and told our cardiologist we're going to hang a cardizem drip and see how it goes. And that's what we did. We hung a cardizem drip, and she immediately got better. So if you're treating with one modality, you're thinking you're going down one road and nothing is working, don't keep going down that road. Try the other road. It's probably the other road, right? So, kind of lesson of the day. You might think it's one thing, right? All these criteria might point you in one direction. It's not going to be 100%, but might point you in one direction or the other. If you go down that road, go down that direction and that treatment, and it's not working, just switch gears, go down the other road, see if that works. And the other road is probably going to work. And don't forget about your patient's history. As always, if you have any questions whatsoever about any of this, please feel free to let me know.